20%. If their CAC score is greater than 0, consider a statin for that 5 to 7.5% group, and definitely in the 7.5 to 20% group. So a great decision table for how to utilize and incorporate CAC into your preventative health care for these individuals. Here is actually another algorithm, which was from the 2019 American Heart Association guidelines, and again, you can see that essentially for this intermediate group, consider measuring CAC for an improved risk stratification, and if it's greater than 0, or if it's equal to 0, then it lowers their risk. If it's greater than 0, then it definitely moves towards favoring a statin. Selected candidates for, this is from a different article, selected examples of candidates for coronary artery calcium measurement who might benefit from knowing their coronary artery calcium score is 0. So patients reluctant to initiate statins who wish to understand their risk and potential for benefit more precisely. So you can get, if it's 0, you can tell them that they're at a lower risk. Patients concerned about the need to reinstitute statin therapy after discontinuation for statin-associated symptoms. We all have people that take a statin and basically complain about myalgias, arthralgias, etc. Older patients who question whether they would benefit from statin therapy, and then middle-aged adults whose 10-year risk is 5 to less than 7.5%, which with risk factors that increase their coronary risk, although they are in a borderline age group. So again, all people who might benefit from a CAC score. I love this slide, and this slide really kind of transitions us into some of the stuff that we've done or some of the work that I've done at Gundersen. This is the number of CT scans done in the US since 1980 annually. So if you go back to 1980, 3 million CT scans of the head, chest, abdomen, and pelvis were done. By 2005, it was close to 60 million, and in 2015, it was 80 million. 80 million CT scans done per year in the US. That's about, if you think about it, that's about 1 for every 4 people in the US. And actually, that is the number of people who present to the ER who get a CT scan these days. I don't know about you, but I've admitted people recently that have been pan-CT because they can't find, they don't know what's wrong, so they just CT the head, chest, abdomen, and pelvis and look for something. And it's just crazy because think of how much radiation that is, and then people get concerned about the radiation for a CAC score. But what I believe, and Mike Cantor and I were talking about it, is we are data rich with the EMR. We are data rich and action poor. All of that data from all of these CT scans is just sitting in the chart. And there's a lot of information there that the radiologist never reports out that might be helpful. So I got interested in this because of the fact that as we admitted patients with chest pain, I looked back at some of their imaging studies as I would go through their chart. And whenever they had a CT scan, I would, especially of the chest, I would look at it and I would look at the vessels, look for coronary calcification, and look for aortic calcification. And I was struck by the correlation between what I saw on those CT scans and the likelihood that they ended up with significant coronary disease. So back in about 2010, I had a resident that was interested in going into cardiology and was looking for a research project. I said, why don't we, we've got all of this data, why don't we go in and we'll see how many people have had CT scans that ended up getting a heart catheterization and look at whether or not those correlate with each other. So as we pulled data, I loved this study because this was really one of the first studies that looked at aortic atherosclerosis as a predictor of obstructive coronary disease. And what they did, this is a very small study, and I would note that one of the authors is Matt Budoff, who is a good friend of Bob's, and actually someone that we've been on phone conferences with, and who has studied this question really in depth. And basically, what they did is they took individuals who were going to have a heart catheterization, I believe it was 97 individuals, and they did a CT of their aorta to look at both CAC and TAC, thoracic aortic calcification. And what they found was that there was a pretty good relationship between those two. And so what they did is they looked at, any thickening of the aortic wall, any luminal irregularity, which would indicate plaque, and then calcification. You can see calcification in the aorta as well as plaque. And then they correlated that with coronary disease. And what they found was that the individuals, so if you look at the coronary disease and the no coronary disease group and the coronary disease group, 60 of the 97 individuals did not have coronary disease. And you can see about 20 of them had plaque, and about 15 of that group had coronary calcification or aortic calcification. If you looked at the group that had coronary artery disease, a much higher percent had aortic calcification. So there did seem to be some type of a relationship between CAC, which was actually twice as high in the coronary group as the non-coronary group, and TAC, the thoracic aortic calcification. So Matt went on and did further analysis with the MESA study population group, and they found a much stronger correlation, interestingly, for this group in women, which was really interesting. So this is the Kaplan-Meier survival estimates for TAC equals 0 and TAC greater than 0. You can see in men that this is all-cause mortality. The TAC greater than 0 group had much higher all-cause mortality, same with women. And then this is the total population, and they combined TAC and CAC, and you can see the TAC greater than 0 and CAC greater than 0 group had the highest all-cause mortality. So this is just a summary of all of the different analyses of thoracic aortic calcification and the risk of coronary artery disease. And it's a mixed bag. And the one thing I read that I thought was really a really good summary of the issue was that, and this is from Desai et al. In Journal of the American College of Cardiology, screening with the primary purpose to assess for TAC, thoracic aortic calcification, has not met the standard of a clinically relevant risk factor that would result in treatment changes. And I think that's fair. I'm not here to tell you that you should go and order thoracic aortic calcification score or testing on any individual. What I am saying is that there's data in the chart already on many of your patients. So what we did, this was a small study. Like I said, we're not a research institution. This is a small study. And we just took 100 charts, and what we did is we looked at people who had had cardiac catheterizations in the year 2007, who had had a CT scan of the chest, abdomen, or pelvis in the 5 years prior to that. And all patients that in this study obviously were symptomatic. They were getting a cardiac catheterization for one reason or another. They either had chest pain, dyspnea, heart failure. Additional information, collected demographics, their comorbidities, diabetes, difference, tobacco, and their medications. To assess their aortic calcification, we used bone windows on the PACS viewer, and basically we went from the aortic root to their bifurcation, and we categorized them as no calcification, minimal calcification, moderate 30 to 70%, and severe greater than 70%. 45 women, 55 men, 34 to 85 years of age. Framingham risk score was calculated for 86 out of 100. 22 patients had no aortic calcification, 39 had minimal aortic calcification, 26 had moderate aortic calcification, and 13 had severe calcification. So these are our results. So in this group, this is the no calcification in the aortic group. And you can see that 73%, almost 3/4 of those patients ended up not having any coronary artery disease. No. And as you saw more and more progressive calcification in the aorta, you saw a higher incidence of multi-vessel disease, with the highest occurring in the severe calcification. So over 70% of their aortic windows showed evidence of aortic calcification. And almost 40% of those individuals had 3-vessel coronary artery disease. We kind of broke it down by Framingham risk score. So there were 25 individuals that scored less than 5%. 7 of those individuals actually had coronary artery disease on catheterization. 4 out of 7 showed aortic calcification on the imaging. and you can go all the way up to the severe, greater than 20% risk. 4 out of 4 of those individuals had calcification. The interesting thing is that none of the 4, despite having a greater than 20% risk of coronary disease, none of the 4 were on a statin. 15 patients had both chest and abdominal CT scans. 1 patient had no calcium on either and had no coronary disease. 2 had the same degree of calcium. 1 out of 2 had coronary disease. And 2 patients had no thoracic calcification and no coronary artery disease in the group that 11 that had greater abdominal aortic calcification. So this is a case right out of our data set, which I just love. So this is a 64-year-old gentleman who developed chest discomfort. This is snow shoveling season in Wisconsin, by the way. Everyone gets chest pain shoveling snow. Lots of MI, people come in with MI shoveling snow. So this guy was shoveling snow and developed chest discomfort, had a history of hypertension, diabetes, was not a smoker. His Framingham risk score was 18.4%, had declined statin therapy multiple times by his primary care physician. Interestingly, had a CT scan of his abdomen and pelvis 2 years earlier. I'm not kidding you, this is one of his images right off from his abdominal pelvic CT, and right at the bottom of his heart you can see his LAD calcified, and then this is his aorta. This is sitting there right in the chart. Perfect evidence to try and convince him to go on a statin. He ended up having a heart cardiac cath that showed severe 2-vessel coronary disease, had bypass surgery for those, and did fine. This is a guy who was admitted for elective AAA repair. He was not an endovascular candidate. He had been evaluated in the vascular clinic, showing mild, and had a cardiolite study showing mild reversible ischemia. He was cleared for open repair. Here's his CT scan from 2 years earlier where they looked at his aorta to kind of gauge whether or not he would be a candidate for surgery. And on that study, 65 out of 68 slices had aortic calcification. From our data, there was about a 62% chance that he had significant multi-vessel coronary disease. Because he had a cardiolite that showed mild reversible ischemia, he was cleared for surgery. Post-operatively, he had 2 myocardial infarctions and 3 strokes and died about 19 days after surgery in the hospital. So, conclusions, aortic calcification is readily identifiable on CT scans of the chest and abdomen and obtained for other reasons. It can be a marker for increased cardiac risk, and you can use that information in your discussions with patients to try and convince them to be on a statin for primary prevention. You can also use that information to help elucidate whether or not someone's atypical chest symptoms might be due to cardiac disease. The last case in my presentation, which you can look at, patient I just saw this year, 70-year-old guy, in for his routine physical, history of GERD, history of hypercholesterolemia, non-smoker, really healthy guy, hunts, fishes, he's active, and came in and he had about 2 or 3 episodes of what he said was bad reflux. You know, he's really substernal, not when he was active, he was just sitting around, not doing anything. But it made me just really nervous as he was talking about it. Did an EKG, that was normal. And I said, well, we could do a stress test. We can get that probably scheduled next week. Or we can do this test and kind of look at your coronaries and get an assessment. Looked at his coronaries. He had actually a Gaston score over 8, or around 790, I think. And I'm like, oh, God, this is horrible. Reviewed it with one of my cardiologists. He said, yeah, I need to see that guy. So he saw him the next morning, talked to him a little bit more. They decided that they were going to do a cath. At cath, he was found to have a 95% occlusion, proximal stenosis of his RCA, and a 95% stenosis of his LAD. And the very next day had 3-vessel bypass surgery, and does great. He did great, and that's good because he's the father-in-law of one of my colleagues. And so, for him and his family, I am a godsend. And so that was how I used CAC in that instance.
Stay here, Mike.
Okay.
That's brilliant.
Okay.
I mean, I really do like that, and I'm taking this back home. One aspect of this is the precise advice you can give about statins, because certainly in Europe there's, well, you know the controversy about that. Is Gunderson a integrated finance and delivery system?
Yeah, so Gunderson, up until 3 years ago, Gunderson actually owned its own physician-owned health insurance company, the Gunderson Health Plan. Because we were small, we felt like we needed to do something to make it bigger, so we actually merged the Gunderson Health Plan with the Unity Health Plan to form Quartz Health Solutions, which is, again, a physician-owned health insurance company that is co-owned between us and UW-Madison, with which we do a lot of work. We're their Western campus for their medical school. So we utilized that in our delivery of healthcare and really and as a mechanism to decrease the cost. Our goal this year was to have a 0% fee increase for Quartz patients in their their out-of-pocket cost for care. And our partner with that is our own insurance company that we co-own. So that's, it's been an advantage.
I think one of the things for selling it to folks back home where I come from would be the opportunity, to link it to research, which we could do. But guidance about how best to target the groups that are most likely to benefit if we don't dig into scans already done. Do you have are you evolving a policy on that, or do you have a policy?
No, we do not have a policy on that.
Do you have a policy of regularly checking scans in the EHR? And could you use new technology to just run the machines?
Yeah, so actually we talked about that last night a little bit. So we actually have a young radiologist who is one of those techno savants who's really interested in AI. And so he believes that he can create he trained at Duke, and he believes he can create an AI that will actually scan CTs automatically for this and quantitate it. So that's one of the things that I think down the road would be a really nice tool, because this is not usually reported uniformly. There are some radiologists that will report it, but it is not uniformly reported on radiology reports.
And I think that it wouldn't be too difficult to fund that project. Okay, we've got about 8 minutes before we need to pick up lunch and get ready for the next session. You've got the questions about thinking about, does it apply to your folks? You can see the drift of some of my questions. I think, Michael, your hand was raised.
Really interesting talk. We could go in many directions, but I always like to think about what could get implemented immediately. And what strikes me is radiologists routinely seeing calcifications. Some of them report them out, some of them maybe don't. But it seems like there's a huge opportunity to just start paying attention prospectively as scans get done. Do you have any thoughts about how one would do that more systematically?
So I think the more radiologists that I talk to actually do incorporate it into their report. I think right now we're probably at about 30 to 40% of our reports will have a comment on whether or not there's aortic calcification, whether it's thoracic or abdominal. So part of the issue is, do you report it as a binary, okay, it's present or it's not present, or do you try and quantitate it? Because there, at least from our limited study, it does look like there is a difference between severe and maybe minimal aortic calcification. The AI would be able to maybe quantitate it, because really it sounds like the computer is reading the coronary artery calcification score for the Gaston score. So could you utilize a similar AI to do the same measurement in the aorta? The aorta and the coronary arteries are different in the atherosclerotic process. In the coronaries it's mostly intimal, and in the aorta it's intimal and medial. And certain diseases have a predilection for one versus the other. Atherosclerotic disease would be more intimal, but diseases like, diabetes and end-stage renal disease, they tend to have more medial calcification. There are a lot of questions to answer before you get there.
Well, I guess what I'm saying, again, what can we do now? If radiologists simply report it out, there's a little bit or a lot in a non-standardized grading system. I'm kind of thinking some patients, the concept of cardiovascular disease may be totally off their doctor's radar screen, so this would at least trigger it. Maybe some, they're debating on statins, it triggers a conversation, and it's something that could be done without getting into big debates about risk stratification scores and routine screening. This is just thinking about the patient a little bit more in depth when we're...
Yeah, because right now this is just one-off for me, and this is the patient in front of me. I look to see if they've had any CT imaging, if they're in that intermediate risk category, and then I determine how hard I push based on what I see in that individual's chart. So but interestingly, so J.D. Billings, who's the radiologist that I was talking about, he believes that we should just run AI on everyone and then report them to their PCP as you're describing to say, hey, just so you know, this individual has extensive aortic calcification and might be at risk for coronary disease, so you can maximize. We have that same process in place for incidentally detected pulmonary nodules. So you're in the ER and you're getting a chest CT for a PE, and oh, by the way, the radiologist notes that you have 3 pulmonary nodules that are 4, 6, and 9 millimeters. That's reported to a central repository in the pulmonary department, and there's a nurse that goes through each one of those to make sure the patient gets appropriate follow-up, because what we discovered about 8-10 years ago was that nobody was acting on any of that. And so we put them into a database, and then we track them over time to make sure that they get the appropriate interval follow-up.
I think we've got time for one question from Dr. Morrison.
This is very quick, so you might be able to squeeze somebody else in.
LA County Public Health, Dr. Morrison, thanks for being here.
Hello. I was just going to highlight, I think it's an interesting idea to use it as a patient teaching moment, because I do think the idea of cardiac risk is pretty like what are you talking about? And I'm a primary care doctor. I have such a hard time with statins. They're just like, what is in the media? People are always hearing something about statins. And so to be like, I saw it in your CT scan. The flip side of that
That's exactly how I say it.
Yeah, but
I actually showed them the pictures, and it really, that drives it.
Yeah, I mean, anything we can get. The flip side of that, though, also as a primary care physician, is now my patients reading on the patient portal their own, results, and maybe the patients who are already taking the statin who are like, no, I see